So the combined American, European, Japanese, Latin American Thoracic Association criteria for the diagnosis of UIP on CT is that basal peripheral predominance, reticulation, honeycombing, plus or minus traction bronchiectasis, and no so-called inconsistent features. So when you're reporting fibrotic lung disease, you're trying to categorise into one of three categories. You've got definite UIP, which is what this is. Then you've got so-called possible UIP, which is all of those things without the honeycombing. So it's basal, it's peripheral, there's reticulation, there may be some traction bronchiectasis, but there's no honeycombing. And you've got these inconsistent with UIP category, which is your third column. And that's got a number of things we'll talk about later, but upper zone predominance, ground glass, air trapping, and a few other features. And that's how you're trying to pigeonhole what you're looking at. Is it a definite UIP? Is it a possible UIP? Or is it inconsistent with? Because this is what drives management for the respiratory physicians. If you call something definite UIP and the patient goes on to get a lung biopsy, 95% of the time, the pathologist is going to say this is UIP. You calling it UIP on CT precludes the need for lung biopsy and sends them down a management algorithm that makes a big deal of difference to how this patient is going to be treated. In Australia, there's now anti-fibrotic agents that are approved on the PBS for use in patients with a definite UIP CT, and that's a very specific course of management. So that wording in the report is really key. When you've got something that's either a possible UIP or inconsistent with UIP, you want to see if you can take the next step and suggest another category of pattern. The approach to fibrotic lung disease is that you are trying to characterise the pattern. What you are not trying to do is guess the disease, because the temptation to say, oh, it's honeycombing, this patient's got IPF, idiopathic pulmonary fibrosis. And they might. That is the most common cause of a UIP pattern on CT, but it's certainly not the only one. Patients with rheumatoid arthritis will have a UIP pattern. Many types of drug reaction fibrotic lung diseases will also have that appearance. You're not trying to second guess the background of the patient. That's the job of the respiratory physician. Your job is to try and say definite UIP, possible, inconsistent with, and then see if you can take the next step in those second two categories and get any more information out of the case. So you might have a case like this. This is that same one that we've seen. We've got that definite honeycombing. The report is usual interstitial pneumonia pattern fibrotic lung disease. Or you might have something like this, where you've got fine reticulation, not seeing any honeycombing. Again, it's still basal predominant, it's still peripheral in its distribution. You've got a bit of traction bronchiectasis here, certainly not seeing any of those honeycomb cysts. And the sagittals show that distribution beautifully, where the upper zones are clear and it's all very basal predominant disease. But the other thing that it has is this subpleural sparing. So the immediate subpleural lung is clear. All of that abnormality is peripheral, but sparing the immediate subpleural lung. So this is still technically a possible UIP pattern, but the next step beyond that is cluing into that subpleural sparing, because this is a typical feature of non-specific interstitial pneumonia, so NSIP pattern. That is almost always associated with an underlying connective tissue disease that you may or may not know about. Again, another case, fine reticulation, the apices are relatively normal, it's a basal predominant disease, there's no honeycombing, there's a tiny little bit of traction bronchiectasis here, there's a few abnormal irregular airways. So again, this is in that middle column, this is a possible UIP pattern, fibrotic lung disease. And again, you think, ooh, a little bit of subpleural sparing. So the report reads, possible UIP pattern, fibrotic lung disease, favour NSIP. So in lower zone fibrosis, we're looking at UIP, which is the most common pattern of fibrotic lung disease. We're trying to categorise into that definite, possible or inconsistent with, and in those second two columns of possible and inconsistent, we want to see if we can go the next step further. We want to see if we've got any features that are going to point to something like NSIP as the underlying pattern.